Recording over here. I'm rolling over here. Oh gosh. That's a start to it.
There we go.
Jackson, so nice to meet you.
Nice to meet you.
Oh man, well, this was kind of an unexpected interview, we'll say. We came to Phoenix, Scottsdale to do some work, but it's always good to see a Medical College Georgia alumni.
Yes, sir.
Anywhere in the country. But you have a unique story that I really think people need to know out there, whether they're a medical student, pre-med, and most definitely a current resident.
Indeed.
So before we get into that, we just say, let's do a brief introduction, where you're from,
Sure.
what you do, and kind of what the future holds.
Yeah. So, like I said, I'm Jackson Reynolds. I'm right now a third-year internal medicine and pediatrics resident here in Phoenix at the University of Arizona College of Medicine, and went to Medical College of Georgia for medical school in Augusta, indeed, and University of North Georgia in Daunting for undergraduate biology and chemistry degrees, with a little post-bac work also elsewhere. So graduated class of 2021, matched out here for internal medicine and pediatrics, and currently I'm a third year. The decision to have not necessarily a switch of specialties, but an addition of specialties beyond residency came early to midway through third year. The initial ideas kind of started floating around in my head late second, early third year, and started to take form as third year progressed, and I started thinking more and more about what I wanted post residency graduation practice to look like. And so ultimately, long story short, the decision was made to pursue psychiatry residency training upon completion of my current internal medicine and pediatrics or med-peds training.
Gotcha. And for many people, that is probably a terrifying sentiment. You know, it's years added upon many, many years already dedicated. So, you know, was there any particular event throughout your current training that maybe hinted that you needed to make a change?
It wasn't any watershed moment with anything that happened in or outside of the hospital. I'm not coming to this as somebody who hates his job or anything like that. So for the most part, I do enjoy the majority of what I do, but there is not the degree of passion and excitement for a lot of what I do that I expected there to be as a medical student looking forward to what residency would be and what treating the conditions and patient populations that I anticipated interacting with would end up looking like. And so as I learned the workflow, not from the medical student side, but from the intern and senior resident side on both the internal medicine and pediatric side, and found that, okay, I'm in the groove of these things. Here's what it looks like in the emergency department. Here's what it looks like on the wards. Here's what it looks like in this specialty clinic or general clinic. My ability to become a better doctor and learn more about my patients, learn what I'm doing increased, but my recognition that I was not being able to put my teeth in the substance of what I was most interested in also started to float to the surface. And so I'm very interested in the social history, and some of the feedback I got intern year was, let's not have so much of the social history, you know, that stuff is relevant, but we need you to refocus on what's going on medically with this person, what's the metabolic issue. And that was fair criticism, because I would be so interested in what was happening with the social history, what brought this person into the hospital, what was the context, what was the background that wasn't just medical, that I would sometimes spend more time on that than formulating the plan for what needed to happen to address the current metabolic issue or cardiovascular issue. So I was in my apartment one night early in third year listening to an audiobook by Anna Lemke about dopamine. It was a very interesting book, and she's a psychiatrist in Southern California, and I'm listening to the stories of her patients and thinking, this is so interesting. Why do I spend most of my time, other than reading about nutrition, which is my other just passion and pet hobby, that sometimes is difficult to incorporate to the degree that I want to within medicine, why do I spend all of my time looking at social things and psychological things in my personal study and when I'm spending my own time pursuing interests? I'm not sitting around reading about how to deal with that positive C ANCA or management of diabetic neuropathy, even though these are a lot more internal medicine and pediatrics relevant topics. And so I thought to myself, man, I should be a psychiatrist. I thought I wanted to be a psychiatrist for a brief period in medical school before I had some clinical experiences that made me turn the other direction and think I needed to pursue something else. But I thought maybe I need to come full circle with this, and the original desire and academic interest that I had there would translate into a more fulfilling career than what I'm doing now, especially if I'm able to finish what I'm doing now and still incorporate that in my ultimate practice, as opposed to, I don't want to abandon internal medicine or abandon pediatrics, but I don't want to leave training with just those skills, and I want to have a different set of skills that will equip me to do, I don't know what yet, but something cross-domain. This is too long of an answer, so I apologize there, but that's the short of it.
Not at all, and I think that gives one some really, really good insight. As a medical student, I remember being told, as far as like, how do I choose a specialty? I got some advice from some residents. I was like, find the thing that you don't hate reading about when you come home.
That's good advice. That's very good advice.
And find that, and that was something that I took to heart when kind of deciding between really orthopedics and anesthesia. And I also love the fact that you have this attitude of adding on.
Right.
You're not completely forsaking that time, and I think the sentiment of a lot of people who switch, whether that be in medical school or even residency, is feeling like that time was wasted. And I love that you have such a different perspective on that is so counter to what probably everybody else in the medical field has.
Yes, sir. I do not feel that any of the time is wasted at all. Even something as disparate from psychiatry as neonatology is not wasted time. Any part of the current training is not wasted time. And I would say, as general life advice for anybody, almost anything you do where you are learning and growing is not a waste of time. Even if it doesn't feel that it's directly applicable to the ultimate domain that you want to function in, be that personally or career-wise or an amalgam of those things. Nothing is wasted time. I did kind of a PGY3 sub-I in the psychiatry department at the adult hospital where I work in October of last year. And the overwhelming overlap between metabolic illness and psychiatric illness that we were seeing on our inpatient unit, and the relevance and usefulness of knowledge in internal medicine, and I assume to a lesser extent in that domain, but to a greater extent in other domains within psychiatry, pediatrics, was very apparent. It was apparent to the other residents that I was working with. It was apparent to those attending physicians. And so I felt that I was able to, even though I didn't know as much about psychiatry as the senior residents that were already in the psychiatry program, I felt that I was still able to very meaningfully contribute because I had this extra knowledge from a different domain that could crosstalk there. Nothing is ever wasted time. Anytime you grow as a person is not wasted time.
I completely agree. And yeah, this is not at all the same level of experience as a full-on residency training, but even my time when I thought I wanted to do orthopedic surgery, coming back to the other side of the drapes in anesthesia, I feel like I became a better future anesthesiologist because I was able to understand the nuances and predict the things that the surgeons needed. And so yes, I spent a lot of time and hours on that side, but even in that short little time, and that's a very minute example compared to the vast amount of knowledge that you've gained over the course of a residency training program, but that's just to hammer home the point that for anybody out there who is thinking that this is the track and the decision that they need to make, it shouldn't be a feeling of giving up or wasted time.
I completely agree. I think giving up is the completely wrong way to frame it. Even if you're in your residency and your situation is not mine and you hate your job, you picked the totally wrong specialty, you derive no joy from what you're doing, what you're learning is still teaching you something that's useful. One, you're learning that you don't like doing what you're doing. And you're also learning, hopefully, as you make the transition, that the sunk cost fallacy is one of the worst quicksand-filled pits that exists. It is very, very easy to say, I have put in this much effort and time in something. If I have to add on additional training or switch to something else, that is going to be either wasted time or time I'll never get back. You won't get back those years. Nobody's ever getting any younger, but it is like a fine wine. everything you do in training. So even if you're in a position where you don't like what you're doing and you don't think that there's going to be relevance, there will be relevance you won't see until you're on the other side of those drapes, like it was in your situation.
Quite literally and figuratively as well. So, for those people out there that are desiring to get out of that quicksand,
sure.
Right? What does the process look like? Because I only know one other person closely that has made a switch during residency.
I think it's very difficult to generalize. So this question will have a lot of asterisks in its answer. For me, the process is still not entirely clear. For a lot of people who have already completed an intern year, especially in something general like internal medicine or general surgery, people do a lot of transitional years or prelim years and those things. It is sometimes easier to get another PGY1 position than going through the match again than it is to get a PGY2 position, which deals with the availability of those things, people switching out or quitting programs for various reasons. Within psychiatry specifically, the options are a couple things for me specifically, and this is very unique to my situation, so its generalizability again will be somewhat limited. But the American Psychiatric Association has a listed posting of listings on their website of open positions at PGY2 and above within psychiatry for people who are wanting to switch from their current psychiatry program or switch into a PGY2 position from an internal medicine or general surgery or other program where some of what you've already started will be able to count as credit, right? Mm-hmm. And so you can count up to 12 months right now. ACGME and American Board of Psychiatry and Neurology allow that to happen from your existing training if you have had up to 12 months of training that's relevant to that. And then you can apply to those things basically just by email or phone call. It's not through ERAS, it's not formal, it's, hey, I'm here at XYZ program, I'd like this PGY2 psychiatry position at your program, can we talk? So it's a lot different than ERAS. That's the current situation with people transitioning in the middle. You can always go back and apply through the match to a first year position, or some psychiatry programs do offer their second year positions when they are available through the match, though my understanding from speaking with people in psychiatry is that is very much the minority and is not a reliable way just because of numbers. So that's the current situation with where things are.
All right. Mm-hmm. So there's plenty of options out there.
There's plenty of options, but it's not straightforward, and you definitely need to do the legwork of talking to people within the department you're interested in. I think that there is a significant poverty of information on the internet about this. Reddit does not seem to be very reliable. There's just, I had this friend, he hated his surgery, I think he's a neurologist now, very vague information like that.
Okay. So kind of moving forward, I'm sure there's a ton of people out there that are probably watching, listening to this, going like, oh man, this is me. And maybe they're on the fence of whether they should just pull the trigger and make that switch. What would be your advice coming from somebody who's quite literally living through that situation right now?
As to whether or not to pull that trigger and make the switch?
Absolutely.
Great question. I was speaking with a pediatric gastroenterologist at my children's hospital, Dr. Paul Tran, a couple of weeks ago, and he made the interesting comment when we were talking about this particular topic that you need to be excited about the mundane in whatever specialty you pursue. So if you're not excited about suicidality and psychosis and just clinical depression, and ADHD, you should not be in psychiatry, because that is the bread and butter of inpatient and outpatient, right? Generalized anxiety disorder, this is going to be 25% or more of your outpatient population as a psychiatrist. So if you find that boring and you only want to deal with dissociative identity disorder and other fascinating textbook and TV medical drama conditions in whatever that specialty is, that's not the specialty for you. So you think about what the real bread and butter is, not the interesting zebras that you saw once or twice during your time at the academic medical center, the incredible open heart surgery, where we did this, a new technique with a different graft of some vein. That's not going to be your day-to-day in surgery. That's not going to be your day-to-day in internal medicine. So if you don't love hyponatremia and you aren't interested in working up that vaguely positive ANA, internal medicine on its own, probably not, inpatient at least, probably not the thing, right? And if you can look down the down the years, sitting out ahead of you and say, what am I going to be excited to get up about every day? Am I going to just kind of slog my way to work and do this job that I may be pretty good at, but it may not bring me that much excitement or joy? Then it is time to make that switch. But I think there's a big danger there as well, because the grass always seems greener. And if you think, I'm not very excited about the bread and butter within what I'm doing, it can be easy to think, yeah, I would be very excited about the bread and butter. Internal medicine is not for me. I bet I would love doing a whole bunch of lap choles. I should just switch to general surgery. Is that really the case? Are you really going to be happy doing a bunch of lap choles? Are you really going to be happy doing a lot of routine endoscopy as an adult GI person, right? If that's not the case, then think long and hard about what it would look like on the other end of this, because if you're switching not because you don't like what you're doing and you don't know what you're switching into, if you're not switching because you know you love what you're about to switch or add on, then you're making a different kind of mistake that will probably end up with the same thing happening all over again in your second, third specialty Groundhog Day.
That is a beautiful way of putting it. Go towards what you love, not run away from what you hate.
Right.
And that's how, it sounds like to make this proper decision, wherever that be in your course, and if it's in residency, this is just a true testimony to let people know that there is a way out, even though
there is.
We're all cornered into this mindset of you sign yourself to this one specialty, and that's it.
Right.
You can't change.
Locked in forever. Right, it's not like being a physician assistant, right? You can just kind of remain pluripotent forever. It's very different in our world. And so if you are there in the position, you think, I want to maybe do this, but you're not sure if you're running from what you hate or running toward what you love, or maybe that you are just bored in the drudgery that is all residencies and all specialties, right? To some degree, a lot of scut work. If you're not sure where you fit on that continuum, I would encourage you, talk to your program leadership, do what I was fortunate enough to be able to do, and do that PGY fill in the blank sub-I, and go see if you are an internal medicine or neurology resident and think you have to do surgery and that's the only thing that's really going to bring you fulfillment. See if you can use an elective to go and do that surgery rotation, not as a third-year medical student where you're having this very, very limited exposure to what's really happening, but as a resident within your program.
And it's incredible to know, again, that option is there. That's something that I was not aware of. I'm coming from the perspective of a medical student, so this has completely changed my idea on how residency is structured and the flexibility in it, and I hope it sheds some light on how this process can go for those out there.
I hope so. I do want to mention that it may not be the case for your particular program wherever you are, whoever is watching this. I'm very fortunate. I'm in a very good program with very good leadership who is very invested in actually doing what is best for each resident. One of the things that attracted me to this program during my interview was how tailor-made the curriculum was for every resident. One of the residents who interviewed me really wanted to pursue a ton of extra work in POCUS and was able to do that and then go on to a POCUS fellowship. I don't know if that would be the case everywhere. I'm just very fortunate in how positive my current leadership has responded to this decision and how helpful and accommodating they have been. I hope that's the case for everybody, but it may or may not always be possible to just do that extra experience.
Well, at least if this story is sounding similar to I guess what people are thinking, at least explore that option.
Absolutely.
But guys, thank you so much for just having this brief conversation with me. And do you have any recommended resources, if anybody or people to go to, really?
That's a great question. This is the one domain where I think the answer is no. I think more of what you and I are doing right now needs to exist. People talking about this. I think there is a lot of fear and shame and, I'm going to have to apply to the match again maybe, so I should be very careful with what I say and have to try to hide my social media and all that kind of stuff like people are in medical school again with the idea of applying to a new program. I think that's a terrible idea. I think you should be yourself from the beginning. I put put my Instagram handle on my ERAS because I wanted to see what to see what they're getting into, right? So I think you go to the places that want you for who you are, and don't be afraid to talk about this concern if you have it. More stuff like this needs to exist because there isn't much out there. The internet right now is not a great resource because so few people are talking about this, except my sister's husband's cousin once had a friend who did switch from ortho to psychiatry, and he's a lot happier now. That's about all that exists. It's a lot of third-hand nothing. So I wish there were better resources, but hopefully this can be the kindling for more of those to exist.
I hope so as well. Well, John, thank you so much.
Thank you, absolutely, my pleasure.
So.
All right, cool.
That was awesome.
Hopefully, that was
That was so good.